There are no 500-year-old hypochondriacs. Why would I say such a thing? I'm going to explain in this video. Hello, I'm John Foster. I'm a medical doctor who does Social Security disability exams. I've done over 1,500 of them. And today I'm going to talk about the overlap between psychological or functional illness and physical illness, and how it's easy to get confused or fall into a trap. As usual, everything I say reflects my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. No 500-year-old hypochondriacs is a saying that I invented, and basically it means be very careful before labeling a patient's problems as hypochondriacal, because even hypochondriacs get appendicitis and heart attacks and all the other physical illnesses that people who aren't hypochondriacs get. Another much older aphorism that I like, over 1,000 years old, is mens sana in corpore sano, which is Latin for a sound mind in a sound body. Those ancient Romans understood that psychological health and physical health were inseparable. Last week I discussed a patient where I was unsure if their problems were psychological or physical, but I suspected their problems were due to hyperthyroidism. I'm going to give several other case studies this video, all based on my own experience, and nobody needs to worry about patient confidentiality because all of these examples are decades old. 20, 30, 40, even almost 50 years old. Now, the first thing to understand is sometimes physical disease will first show up with psychological symptoms. Hypothyroidism, low thyroid hormone level, can show up as depression, whereas hyperthyroidism, overly high thyroid hormone level, can present as anxiety. Sometimes the first symptom of cancer is also depression. On the flip side, sometimes psychological disease can show up with physical signs or symptoms, an example being lichen simplex chronicus. A while back, an Asian female presented to me with a rash on the back of their neck. This person was involved in an extremely difficult university course and was also having relationship problems. On examination, they had a red elevated patch on the back of their neck, which is known as lichen simplex chronicus and is due to a nervous habit of rubbing the back of the neck, usually when anxious, and it's most common in women and also most common in Asians. Then third, patients can present with a mixed picture, partly psychological and partly physical. In fact, mentally ill patients are at higher risk for physical illness than mentally healthy patients for a number of reasons. They tend to have higher incidence of substance use, more smoking, more heavy drinking, more drug use. They may have problems with access to safe and healthy lodging and food. There are higher incidence of homelessness. Mentally unhealthy people tend to have a greater incidence of obesity and also to exercise less than mentally healthy people. All of these factors contribute to a higher risk of physical disease in the mentally ill. To further complicate things, drugs used to treat physical illness sometimes have psychological side effects. Young physicians today will have no experience with the drug reserpine, but when I was a medical student, it was still in wide use as a drug to treat high blood pressure. It depleted sympathomimetic amines, and as a result, a common side effect was depression, indistinguishable from neurotic depression. Other drugs that can cause psychological effects when treating physical problems are various hormones. For example, prednisone can cause steroid mania, and I've seen that in one patient. Anabolic steroids can cause mania as well. I had a man who I treated for hypogonadism with testosterone, and 2 weeks later he came back to see me and was very unhappy because he said that he felt angry all the time, like he wanted to kill someone. It seemed to be a manifestation of dysphoric mania, and I prescribed quetiapine for him, an antipsychotic mood stabilizer, and a week later he felt much better. Conversely, psychiatric medications can cause physical side effects. A while ago, I treated a patient for a migraine with chlorpromazine, a major tranquilizer often used to treat psychosis. This was in the emergency department, and 15 minutes after receiving the chlorpromazine, they were pacing around the emergency department, obviously agitated, and told me that they felt like they couldn't sit still. They were experiencing akathisia, a side effect rare of major tranquilizers in which the patient simply cannot sit still and has an irresistible urge to keep moving. So how about a physical disease presenting as a psychiatric problem? Well, my first experience with in-hospital medicine when I was a medical student was training in a locked psychiatric ward. I spent 3 months doing this, and at one point a woman in her 50s was admitted for a new onset of psychosis. In layman's terms, she'd gone crazy and was out of touch with reality. Of significance was the fact that she was an immigrant from Jamaica. At that time, everyone who was admitted to the hospital got a test for syphilis, a VDRL, and her test was negative. However, I decided to order an FTA-ABS, another test for syphilis, and it came back positive, and internal medicine was consulted, and it turned out that she had neurosyphilis, an infection of the brain that was making her act crazy. The reason why I'd ordered the test: the week before she was admitted, I'd read an article in the New England Journal of Medicine explaining because of the lack of health care in Jamaica, tertiary syphilis was a common issue and often unrecognized. In terms of psychological disease presenting as physical, a while back I discussed a young woman who came to the emergency room complaining that she couldn't breathe through her nose. On my examination, there was nothing wrong with her nose, and it turned out that she was psychotic. She was deluded and believed that she'd stopped breathing 3 months before she saw me. She'd seen an ear, nose, and throat surgeon and was scheduled to have a septoplasty, an operation for breathing through the nose, the next day. Luckily, I was able to cancel that operation and get her admitted to a psychiatric facility where she could get the help she needed. Another example of a psychological disease presenting as physical, I had a middle-aged woman come to the emergency department complaining of a severe headache. On examination, one of her pupils was normal and the other pupil was fixed, dilated, and unresponsive. Usually, that's a sign of a severe brain problem in a patient with a headache. However, in this case, it turned out that the patient had surreptitiously instilled mydriatic drugs in her eye, drops to make her pupil big, in order to convince me that she had a physical disease. She was the wife of an ophthalmologist. The technical term for that is pharmacological pupil, and the way to diagnose it is to instill pilocarpine drops in all physical conditions except for botulism. That will result in constriction of the pupil, but in botulism, the dilation of the pupils will be bilateral, not unilateral. Other examples, I've seen 2 patients present with severe hyponatremia. One was a young man who complained of vomiting, and the other was a middle-aged woman who presented somewhat confused. In each case, it turned out that the patients suffered from psychogenic polydipsia, a psychological condition where the patient is compelled to drink huge amounts of water. Both patients required hospital admission, and when you admit such patients, you need to make sure they don't have access to water. You have to get the maintenance workers to turn off the water supply to the sink and to the toilet in their room. The young man presented repeatedly to the hospital with hyponatremia from psychogenic polydipsia, and eventually died from one episode, which brings up the fact that psychological illness has mortality. There's mortality from suicide, there's mortality from overdoses, there's mortality from accidents relating to being intoxicated, there's mortality from poor health, such as smoking. The idea that because the problem is all in the patient's head, it's not serious or it's trivial is nonsense. One last case I'll talk about, and this is sort of on the borderline between hypochondriasis and psychosis. When I was a resident training in the clinic, I received a chart of the next patient I was to see, and it was a 60-year-old woman, and the chief complaint was feels like she's pregnant. I immediately went to the clinic nurse and asked her what was going on with this patient, and she said, "Oh, she's irregular. Every couple of months she comes in thinking that she's pregnant. All you have to do is do a pregnancy test." At that time, you couldn't buy at-home pregnancy tests in a pharmacy. Tell her the pregnancy test is negative, and she'll be happy and she'll leave. And sure enough, that's exactly what happened. The woman told me that she felt pregnant. I did a urine pregnancy test. I told her that it was negative. She was happy and she left. She came back about 2 months later. We repeated the same sequence, and for all I know, she's still coming to the clinic feeling that she's pregnant. That really intrigued me because at that time, when I was a teenager, I'd had a dog, a female, who we'd allowed to have 3 litters of puppies. After the 3 litters, we had her spayed, but she continued to have episodes of pseudocyesis, false pregnancy, where she'd act like she was pregnant for about a month and make a nest to raise her puppies in. 2 more points and then I'll be finished. The first is, as in the example of the woman who instilled mydriatic drops in her eye, healthcare workers or folks associated with healthcare workers can be particularly convincing in feigning physical disease. I had a respiratory therapist once who feigned asthma by creating a wheezing sound in his upper airway. The second is sometimes it can be absolutely impossible to tell whether a patient's main problem is physical or psychological. And that was the case in the woman I discussed last week, who I think had hyperthyroidism, but may have been suffering from marked anxiety. In that case, my opinion, the best thing to do is be honest with the patient. Tell them that you don't know exactly what's going on, and follow them up closely. Well, I hope this has been helpful, and as always, remember, if it happens, it's possible.